Hello everyone, welcome to the Fast Track Cities Scotland webinar on PrEP and African women in Scotland. My name is Dr. Ingrid Young and I apologise for any background noise that you might hear, the joys of living in a pandemic. I'd really like to welcome everyone to this webinar and to the recording after, should you want to listen to us again. I'm really pleased to introduce a number of people who will be speaking on this seminar on this topic. Who are from Hupenyu Health and Wellbeing, Waverley Care, PrEPster, and I'm based at the University of Edinburgh and part of the Irish network. Can we have the next slide, please, Heather? Just for those of you who haven't been taking part in the event so far, using the platform Zoom, and in terms of asking questions, you can submit questions through the Q&A function, which is at the bottom of your Zoom window, and we will keep track of what you ask and hopefully get to answer at least some of your questions. You can also use the chat function, again at the bottom of the window, and you can comment or send messages to the panelists. I think there is further information there, but as long as you're happy with communicating either via the Q&A for questions to be addressed at the end or via the chat for just comments you want to make or things you want to say throughout, that would be great. Thank you. Next slide, please. And just to say that there were multiple sponsors for this event, but none of the participants in this panel or this panel itself has had anything to do with them. We are funded and involved in other organizations. So next slide, please. So the panel members, actually, if you can put your screens on, Heather, I'm not sure if that messes things up a little bit, but I'd just like to introduce the panel members and they will introduce themselves in their own sessions, but I'd like to introduce Nipa, if you want to say wave. Nipa is the CEO for Hupenyu Health and Wellbeing. Bibiana Zira is a health improvement coordinator for Waverley Care and works with NHS Forth Valley. And Will Nutland is CEO and founder of PrEPster and the Love Tank and does all sorts of things that he'll tell you all about. And I'm Ingrid Young and I work at the University of Edinburgh in the medical school, and I've been involved in the Scottish Interdisciplinary Research in Sexual Health Network, IRESH, for a number of years now. So thank you, everyone. Heather, next slide, please. Okay, so the session is on African women's access to PrEP in Scotland. I want to start off this session by saying that the number of women accessing PrEP in Scotland is incredibly low. It is extremely low. So from the second year report, we know that over 3,000 individuals have been prescribed PrEP at least once in the first 2.5 years of it being available on the NHS, and almost all of them were men, and almost all of them were gay, bisexual, and men who have sex with men. 26 women were prescribed PrEP in the first 2.5 years, and we can't quite align, the numbers don't quite align for us to know the race or ethnicity of those women, but we also know that 14 people were identified as African or African Scottish who are prescribed PrEP in Scotland. So I'd like to start the session by saying we accept that PrEP is an intervention for everyone. It works in everyone's bodies. There might be some things that need to be done slightly differently to make sure that people are fully protected. But at the moment, PrEP is not an intervention that is available to African women in Scotland. I think it's clear to say. And I think we're here to talk about why that might be and how we can change things. Next slide, please. So I'm going to talk about a little bit of research. Next slide, please, Heather. I'm going to talk about a little bit of the research that's been done because, in fact, there has been research done with African women in Scotland in relation to PrEP. There have been a couple of studies. One was done a number of years ago before PrEP was available in Scotland. I ran this study at the University of Glasgow while I was there, and part of it included focus groups and in-depth interviews with people from Black African communities in Scotland. It was both men and women who were interviewed and took part, and including both people who were living with HIV and people who were HIV negative or untested. A second study was done more recently, and this was led by Sarah Nakasone, who is, I believe, now at UCL, but at the time she was at the University of Chicago. This was done in collaboration with a number of us in Scotland and London. And this study interviewed Black, Asian, and minority ethnic women in London and Glasgow. It was comprised primarily of Black African and Black Caribbean women. And this was a study also about sexual health and PrEP and experiences of or attitudes towards that. So next slide, please. I'm not going to spend too much time talking about the findings because I think the findings are really important, but we also want to have a discussion about next steps. But just to give you an overview or a highlight of the findings, the study that I did before PrEP was available identified issues such as stigma and social risks, so the risk of being identified as living with HIV or kind of difficulties in disclosing to partners, issues of mistrust and control, so a person is not always in control of their HIV prevention method if their partner is taking PrEP, and the issues that were related to that and the gendered issues related to that. There was a mistrust of treatment as prevention, and we've moved on quite a lot, but I think there are still anxieties around how effective U=U is within certain communities, but also are people taking their drugs and are they supported to have an undetectable viral load? Issues around candidacy and risk perception. So not a lot of the women I spoke to didn't see themselves as PrEP users and felt the condom worked as effectively as they wanted it to. Next slide, please. And then just another thing to raise is that some of the women were concerned that PrEP would actually increase harms or interfere with existing strategies. And this extract that is on the screen, which talks about actually, are you trying to replace the condom, is an issue that I think we really need to deal with in terms of addressing those concerns, not completely rejecting them out of hand, but listening to what concerns people have and understanding that actually this person wasn't opposed to using condoms or PrEP, they were questioning the bigger impact that PrEP might have. So I think these are things we need to address. Heather, next slide, please. The project led by Sarah Nakasone identified a number of issues as well. There was limited awareness of PrEP, but actually there was quite a lot of enthusiasm for the potential that it had. The role of peer support was identified as really important, but there was a real impact on how specific communities were fragmenting, and there was limited opportunity for peer support depending on your geographical location and also the community that you identify with. There are diverse communities in here. Actually, age plays a really important role in patterns of safer sex and fear of HIV, and this is in particular to generational issues. And there were structural barriers identified, and I think we really need to say from the start that institutional racism really shapes how women feel about and their experiences of accessing health services. So the idea of a hostile environment does not go away because we want it to go away. So there are a number of issues that were raised here that would affect PrEP awareness and uptake. Next slide, please. In addition to the research that was done, we ran a roundtable a couple of years ago because as PrEP was rolling out, there was quite a lot of enthusiasm and excitement about the possibilities, but there was quite a lot of discussion about how PrEP was for women too. Rather than PrEP is for everyone. And I think, so we ran this workshop because we brought stakeholders together from different community organizations and clinical partners, as well as people who have done research in the area to talk about, well, what were the barriers to making PrEP available for women? And this report is available online, but just to give you some of the headlines for barriers to PrEP for Black, Asian, and minority ethnic women, or for Black women in Scotland. The headline issues to come out of this were organized in terms of the HIV literacy framework that I organized or that I developed with a number of partners, where we identified different components of awareness and literacy. So in terms of a willingness to engage with the topic and with PrEP. We identified HIV stigma, how it limits discussions. We talked about language ineligibility criteria and materials can be off-putting, and separating PrEP from and HIV from wider sexual and reproductive health issues is a problem. When it comes to accessing PrEP information, what facilitates that, we identified a lack of specifically targeted services for Black African women. Again, we identified the role that institutional racism plays or in how it shapes the relationship with healthcare. And we identified a lack of the multilingual barriers, the lack of multiple languages, and the availability of that information. In terms of engaging with others, participants at this workshop identified that there were concerns about how you raise this as an issue with your peers as a Black African woman, and talked really about social ideas around are you allowed to talk about the sex you're having with your friends, with your family, with your congregation? What things aren't allowed to be talked about? So I think there was a reticence in terms of how to support women in having these conversations with their peers, first and foremost, before you even get to a clinic or a GP surgery. There were a number of gaps that we didn't discuss, and it's perhaps not surprising given hardly any women at all had accessed PrEP at this time. And so there were no discussions about understanding PrEP information or using PrEP because we simply didn't have that lived experience in the room or available to us to discuss these things. That's going to be enough for me. I think I've raised a number of issues here that we can quite easily come back to. But this was just to give you a flavour of the work that has been done in Scotland so far. I think it's important to come to this with a recognition that we've identified some of the issues and some of the barriers. I think it's important as we move forward, we learn from this, but we also talk about some of the solutions. So I'm going to pass on now to Will Nutland from PrEPster, where he's going to talk about the project MobPresh. So thanks, Will. Next slide, please, Heather, and thank you very much, Will.
Can I have the next slide, please, Heather? Thank you so much, Ingrid. Thank you, HIV Scotland and all of the organisers of this summit for inviting me along and to be part of this. You will notice that I'm not a woman. You'll also notice that I'm not a Black African woman. The funding for the project that I'm about to speak about, MobPresh, was from Public Health England's Innovation Fund. That was 12 months worth of funding that ended just under a year ago. And I would have loved to have been in the opportunity for us still to have had full funding for this project. So someone from this target community would be here with you today reporting on this. Sadly, that is not the case. And so I'm afraid you get me instead. So I'm the co-founder of PrEPster. PrEPster's parent company is called the Love Tank. We're a community interest company. And we have PrEPster has been doing work to educate and agitate for PrEP access in England and beyond. For the last 5 years, we have a great partnership work that we've been doing with HIV Scotland. So almost all of the work that's been Scotland-based has been done in coalition with Nathan and his team and Ingrid. And what I want to talk about this afternoon is maybe what we can collectively learn from this project called MobPresh, mobilising for PrEP and sexual health. Next slide, please, Heather. So MobPresh ran for a period of 12 months, as I said, funded through Public Health England's Innovation Fund. It was a partnership between PrEPster, Yorkshire Mesmac, based up in Yorkshire, and Brigstow, based in Bristol. And the aim of the project was to recruit, train and support HIV prevention, PrEP initiatives with self-identifying women in England. The project was followed a peer-led, a peer mobilization approach. And what we attempted to do was to move the target group of the interventions away from some of those women who we may traditionally see coming to be first in line in some of the PrEP work that we might do. And one of the key things we wanted to do, based on some of the pre-research we did to inform this project, was to accept that lots of the women, particularly the African women who were targeted by this intervention, they told us that they would rather get their PrEP and sexual health information from someone who was similar to them, someone who had characteristics that were similar to them. And we actually particularly dug down and asked around what those peer characteristics might look like. And lots of those women helped to inform the project by telling us that they wanted to find out about PrEP and sexual health from women who were around their own age, rather than traditionally what might have happened from a mother figure, an auntie, and an older woman. So we had some very, very difficult conversations that you can read about in the process evaluation report about what makes a peer, who is a peer. There's a fantastic set of learning from us that we can share probably at another time. We won't have time to do that today, about this kind of notion of what is a peer. There were two pieces of research that we drew on to inform the project. The first was some research that I'd been involved in around gay and bisexual men and how they wanted to access PrEP information in the future. All of them were PrEP users. And again, they followed that same narrative. I want to get my PrEP information from people who are like me. And the second piece of research we used was drawn on a piece of work that we did with the GMI partnership in London that did face-to-face outreach interventions with people who were either using PrEP or could potentially use PrEP. And the research that came out of that particular project showed us that if we asked gay and bisexual men, what are the key barriers to PrEP? The answer was access, I can't get hold of it. And if we asked Black African women, what are the main barriers to PrEP? The answer was education, I don't know about it, awareness. So there's a kind of an additional barrier that these women were facing around PrEP. So the next slide, please, Heather. So MobPresh worked by having 3 coordinators in each of those 3 sites in England, and each coordinator was given a pot of money that enabled her to recruit, train a bunch of volunteers. You don't need to press the video, it's not going to start, it's just a screenshot, thank you. And each cohort of volunteers were facilitated in creating health promotion models around their own communities. And they included, for example, this YouTube video that was developed by one of the volunteers in Leeds. And we think it's the first PrEP video available in British Sign Language. So this particular volunteer has a hearing impairment and wanted to do something that told her peers about PrEP, but using BSL. Other examples included women who hosted dinners and lunches, who did things like went to existing events and had stalls. They gave crash picnics in parks. They went along to demonstrations and helped people understand about PrEP. One of the things we did with a trans youth group in London was that we, rather than going into that group and trying to talk to them about PrEP, we went along to one of their banner making workshops that they were doing for Trans Pride, and we bought, pop and pizza, and were able to facilitate a discussion about PrEP based on an activity that was drawing them together, rather than an activity that maybe they wouldn't have come to if we'd sold it as being about PrEP. Next slide, please, Heather. So the process evaluation report helps us to understand the how and why did the project work, how did it evolve. That's available to download from our website, prepster.info/mobpresh. I want to spend the rest of the time in this brief presentation talking about 2 columns of key learnings. The first column is, I guess, what I would refer to as the kind of the positive things, the positive outcomes of the project. And the second column are the things that not necessarily negative, but things that I think we can collectively learn from. So the next slide, please, Heather. So the first thing is that the process evaluation helped us to determine that the volunteers who were involved in this project, regardless of the site in which they were working in, regardless of whether it was Bristol, London, or Yorkshire, said that they found the approach that was fun, collaborative, and interactive was one of the important things that they'd learned from this. And some of them reflected that the training for MobPresh, the interactive, collaborative nature, really contrasted with some of the other training that they might have been involved in around HIV and sexual health, that they felt often was quite top level being talked to, whereas the Prepster training was much more interactive. Secondly, one of the positive things to come out from the process evaluation was that women talked about their involvement in the information that they were sharing being relatable, culturally relevant, and humorous. Humor kept coming up, and you'll see in maybe one of the photos we show in a moment, there's lots of laughter involved in this project. And one of the women interviewed around the issue around cultural relevance says, when you're speaking with Black people and they see another Black person, they resonate immediately. So again, this reinforcement that if we're going to do work around PrEP and sexual health, this peer approach is relating to someone who is like me is a really important element for us to be reinforcing. And then the third element in this pillar of kind of positive things to take away from this is that the women involved said that it was really important to put PrEP conversations into everyday conversations. It didn't work if someone was asked to go and talk to a group of women just about PrEP, but instead by being trained and skilled and supported into kind of dropping PrEP into conversations in a day-to-day conversations rather than what they talked about, a pitching style or a forcing style was one of the other key pieces of learning for us. Next slide, please, Heather. But what about the things that maybe were not so much negatives, but things that we can really learn from about how we might do projects like this into the future? And Ingrid's kind of touched on some of these already. And I have to say, when I first looked at the draft evaluation report, I got really emotional when I read these things. I got emotional because I felt like we should be doing better, that we should have learned so much more from the last 3 decades of HIV. And if these barriers to doing work like this still exist, then we have way much more work to do than maybe I naively thought. But so the first one is that the mob pressure volunteers spoke about a reluctance to talk about PrEP and sexual health in public. And there was a silence that was linked to blaming discourses about HIV, particularly that HIV only affects gay men. And so there were a whole set of kind of historic issues related to HIV that caused barriers to talking about PrEP. One woman said, what I keep hearing from people is that PrEP makes people more promiscuous. So homophobia, perceptions of homophobia, perceptions of what it means to have HIV, perceptions of sex and talking about sex were all barriers to these women actually going out and talking about PrEP within their communities. The second difficulty, and again, Ingrid's yes.
So you've got 3 minutes left.
Thank you. The second barrier was, Ingrid's kind of alluded to this, was difficulties engaging with some women from some religious backgrounds, and not just from backgrounds, but being able to talk about PrEP and sexual health within religious settings. I think this is pertinent given the amount of resourcing that goes into work with faith leaders and work within religious settings. But the key barrier here was especially around when there were men present. So men within religious settings who were seen to silence conversations, and in particular reinforced entrenched views about the rights of women to be able to speak about sex and sexual health and sexual autonomy. So there's a whole kind of layer here. The one before I just talked about was around kind of homophobia, perceptions of HIV. This one is kind of layers around misogyny and the roles that us as men think women can have or cannot have, and the control that we think we can implant upon women. Next slide, please, Heather. And then implications that these issues meant for the volunteers, the mobilizers, that because they were talking about sex and PrEP, that they could be HIV positive themselves, that they might be deemed to be promiscuous, that they were saying in talking about these issues that women they encountered might mistrust their partners because of some of the narratives that were being talked about. And those women who were volunteers who were already diagnosed with HIV were also concerned about being outed about their HIV status, or assumptions being made about their HIV status that would then out them within their own communities or families when they weren't necessarily open about their HIV status. And then the final one, the final kind of issue for us to learn from on this pillar, was a sense that because of a real targeting of Black and brown women in this project, we deliberately and unapologetically attempted to overserve Black and brown women. There was a sense that by overserving Black and brown women, that the project was reinforcing stereotypes about who gets HIV. And there are two kind of quotes that I've drawn from this. One woman said, "I'm sick and tired of hearing that HIV, Black and brown women are at high risk for HIV." Another woman said, "HIV is not seen as a white person's concern." And so we've, again, in the process evaluation, we talked about how we might switch that narrative around in the future, and how we might be better equipping volunteers and mobilizers to be able to respond to why Black and brown women were overserved within projects like this. Next slide, please, Heather. And so as we go into, yeah, brilliant. As we go into the final minute of this, I wanted to just very quickly talk about the legacy from this project. I mentioned that funding finished just under a year ago. And the two images you see here are screenshots from a booklet that we've just produced. If you'd like a copy, please get in touch. I'd be really happy to send you them. This booklet, or the concepts behind this booklet, were developed at the very last month of MobPresh, actually almost a year ago, with a bunch of MobPresh volunteers from London. And they felt that we needed some new written materials that would help us to do three things around PrEP for women. The first one was to make it clear the circumstances and the situations when women, particularly Black African women, might benefit from PrEP. They felt there was a sense that lots of the narratives weren't really talking or naming some of the key reasons why certain groups of women may benefit from PrEP. And so this booklet named some of those reasons. The second was that it was really important that information talked about control, that PrEP might put me in control. And you'll see just one of them, using PrEP means having more control over your sexual health. But the final thing that is the kind of the thread through this booklet is that lots of the women who were involved in the MobPresh project felt that we needed to focus really on an assets-based approach, this rather than a deficits-based approach. And by that we meant that they wanted us to start talking much more about pleasure, about sexual pleasure, that PrEP may give me more control. It may stop me getting HIV. It may mean that I can negotiate sex I want, but actually pleasure is a really, really important part of the conversation that we rarely talk about. And so this booklet and the poster that comes with it took that legacy forward and produced this booklet and a poster in the set that comes with it. Final slide, please. And so if you want to know more about this project, there's the information about the PrEPster website. I'm really looking forward to the conversation we have in the next few minutes. Thank you all. Bless you, Heather, for the slides, and Ingrid for having me here today. It's been a huge privilege. Thank you.
Thank you, Will. I think we're on to Ya next.
At the next slide, please. Hello, everyone. I'm the CEO of Jalapeno Health and Wellbeing. We are a charity that supports the African community in Glasgow, in Scotland as a whole. And we are here to support people living with HIV, diabetes, mental health, and diabetes and mental health. But at the same time, we educate people, and we are the voice for the African community, and we have the space for them and help them navigate the health service. We had one of our service users, we actually have a women's group that we educate them on all issues. And one of our sessions was on PrEP. So we had a service user who had no idea about PrEP, and she came for the women's group and she was educated about PrEP. But her circumstances was she had been in the asylum system for over 10 years, And now she was in a position where she could go back home to visit her husband. So being armed with this information, she actually went around Glasgow to all the clinics to see if she could access PrEP. From what she said, some of the clinics didn't engage with her. Only the clinic in central Glasgow did engage with her. And they were able to ask her what she wanted, and she told them her plight about what she was going through and how she was going back, and she wanted to take control and protect herself. And they said the only way was to use a condom, and she said, I can't go back telling my husband to use a condom. So she wanted to get tested and to be given PrEP. And they said, we can't help you. The only thing we can do is go and come back and you can get tested. And she freaked out. She was like, what? There was no help at all. She was really, really distraught and came back to the organization. And we just told her, don't worry, we can help you. We actually got her tested. And then we directed her to the pharmacy to go and buy PrEP over the counter. She was like a bit shocked because she honestly thought PrEP was just like a birth control where a woman can have control over her body, like having, making that decision, I've got 2 children, I don't want to have more, so I can access it anytime. And that was one of the big issues. She just didn't understand why she couldn't access PrEP. Bibiana?
Hi, everyone. Thank you, Ingrid, and all the organizers of this event. Thanks for inviting me to speak today and share some of the issues in African communities that we come across when working in communities, in clinics, and with individuals. So today I'm going to share 2 stories, 2 journeys of 2 African people. The first one will be the journey of, the role of the religious organizations in enabling African women's access to PrEP. So this is my journey 1. This is a story of Esther. She is 36 years old. She's a mother of 3 young children. Esther needed PrEP. She has all the information and all the knowledge about PrEP, but there is a problem. She has to run it past her pastor, who knows a lot about her personal issues. And this is normal practice for her, as she sees her pastor as a trusted person. The pastor has advised her against taking PrEP. He advises her that her faith can make her whole and nothing else. So without permission from pastor, Esther cannot access PrEP or medications. So I'm going to raise some issues here. From this story, this is a true life story. There is a clear lack of awareness and understanding about HIV and the impact of HIV on individuals on the part of the pastor. Another issue is there's a complete and total trust and dependence on one source for information, especially regarding health. The system is very, very good in looking for solutions and interventions for certain outcomes, for example, PrEP and HIV, which is very good. But I think there are other things that need to be thought through. So different organizations and different communities will have certain barriers to the uptake of PrEP. For example, in the African community, there is a barrier of cultural practices. There is religious belief as a barrier. And I think Will also mentioned this, there is family dominance or hierarchy. And these will all come into play in accessing PrEP. So these different communities have different dynamics, which needs to be understood before any intervention, for example, PrEP, can work. And so more work needs to be done at grassroots levels to feed back more information and more awareness sessions into communities about HIV and PrEP. Even before we start talking about PrEP, we need to make people more and more aware about HIV. And again, I see another issue with the clinics or the clinicians. This is not so much of a big problem, but I think the clinics need to kickstart these conversations with individuals. So because we know that people from BAME communities are disproportionately represented and are at risk of HIV, I think the clinics, the sexual health clinics or even GP practices should start off these conversations when patients go into their clinics to access services. And this does not have to be an HIV service they are going to access. Just because they are in the group at risk, I think clinicians have a big role to play in starting these organizations to ask people whether they know about their HIV status and advise and encourage them to go and know their status. So these, I think, will be some of the possible solutions to some of these problems we're having. And why am I saying this? Because the clinicians and the healthcare workers are also trusted people in the community. So when they speak, people tend to listen. For example, the example I gave, the pastor is a trusted person, and that's why Esther is able to listen to him and not access PrEP. And whatever the pastor says is watered down to the congregation. So if he says no to PrEP, then it is no. If he says yes, then it is yes. And this is because of what he knows. So he knows he doesn't know much about PrEP. So therefore he's going to water down that down to the congregation. But if he knows about PrEP, if he knows about HIV, he's going to pass on the same message down to the congregation. So there's a lot of work to be done at those grassroots levels, and the work needs to be funded. So more funding needs to come into play so that people go into the communities to continue to raise awareness about HIV and PrEP. Before we can talk about PrEP, we need to make people aware of HIV. The other speakers have spoken and they have said that PrEP is not very well known. It won't be known because people have to know first about HIV. That needs to be tackled first before we can start conversations about PrEP, because we are going to organize an event and say, come and listen to about PrEP. People might not come because they're not sure what PrEP is. So understanding why you should be taking PrEP, first of all, you need to understand what HIV is. So this is the first story. And the second is another journey. This is the role of generational differences in access to PrEP. So this is a story of Ola and Ade, 17-year-old twins who have an understanding and awareness about PrEP, condoms, and their sexual health. But Anita, their mother, found a pack of condoms in Ola's room, and this became an issue. Ola explains it is for her safety. She explains the benefits of condoms for young people. And she also mentioned PrEP as prevention. But Anita, the mother, will have none of that coming from her kids. She reminds them of their religious background and abstinence. Anita stops both her kids from going to access condoms or attending any sexual health service for PrEP, explaining that stigma is associated with such places. And she says, if you are seen there, the people will assume you have HIV. No one will accept us in our family. No one will accept us in our community and our church. But the kids do not agree with this. They feel comfortable attending sexual health clinics and are happy talking about their sexual health needs. But Anita reminds them of how HIV was in the 80s and in the 90s and how it is still very much around and the same. So the key issues I see here are, one, Anita has a lack of awareness about the advancements in medical science. So the older generation see HIV differently to young people. So the generational differences in stigma still applies here. And this is coming from a place of hurt on the part of Anita. So she had seen things firsthand in the 80s and 90s when HIV was a big issue and almost like a death sentence. And young people know about this stigma associated with HIV, but they're open to talk about it, unlike the older generation who have experienced it. And this is a good thing because they're open to talk about it. The more we talk about these things, the more it becomes less of a stigma. So there's a need to support families like this, to support young people who are in this situation, who want to access but have this barrier from their parents who are from the 80s and the 90s. And there's need to support the parents also with relevant information. But how do we support these families and these people in environment, in safe places such as their homes? These are some of the questions that come up all the time. And I will be open to hear from you all what you think. Thank you.
Thank you, Bibiana. Can I just summarize, I think, what Bibiana and Ya told us was based on their work with women, with Black African women in Scotland. And I think they raise some really important issues around not simply what the individual barriers are, but what are the environmental constraints that shape the conditions in which PrEP becomes possible. And so just to summarize, I think Ya's story talked about, in the experience of the woman talked about how clinical eligibility and responses by health workers need to respond to the lived experience of African women. I think Bibiana described it, there's a need to have caring conversations. So how do health workers have caring conversations that traverse these boundaries? These stories also highlight how service provision and health workers, again, I just said need to have caring conversations. And this is about as much understanding if and how that clinical eligibility might need to be changed or might need to be discussed, but also how does the institution respond to people who are asking for PrEP but don't fit into those categories. So how do we engage with that? And I think their stories highlight how, you know, the environmental conditions in the home, in public spaces or in community spaces, in clinics, point to how we need to continue to pay attention to the environmental conditions and how can they continue to be supported and enabled. And this means not just us having webinars talking about these issues, but actually funding the real work that can address those environmental conditions. And that might be long-term, that might not immediately produce a drop in HIV rates, but actually this work is really, really important. So I'd really like to thank Ya and Bibiana for the stories, for the discussions that we've had over the last few weeks in planning this session out, and to thank you for your time. Next slide, please, Heather. So this is where we open it up to questions and comments. Can I ask the panel, everyone, Will and Bibiana, to turn your pictures on, because we love looking at you and we love hearing from you. We've got one question, but can I invite the audience to, those of you who are still with us, to ask any questions in the Q&A. We've got one question and I'll open it up to the panel. One person said, pleasure is so important when talking about sexual health and HIV. How do we encourage people, including sexual health staff, to have conversations about pleasure with service users? Does anyone want to respond to that question?
Shall I give it a go? So I think there's some brilliant sexual health clinicians who are already doing this. There's some great examples I know of clinicians and workers in and outside of London who I'm hearing talking about this both within public forum, within clinical practice. I think the thing is that when PrEPster talks about the tools and the arguments we use around advocating for PrEP, we've traditionally used a handful of tools that involve a public health argument around PrEP, a human rights argument around PrEP, and a cost effectiveness argument around PrEP. And I think that's been the necessity because we've wanted to get PrEP available through our national health services. And we've had to use particularly that last one, the cost effectiveness argument, in order to get it, get PrEP commissioned. Making an argument about PrEP increasing pleasure isn't going to win over some of our public health commissioners and our politicians. And so I think that's taken, the argument around PrEP and pleasure has inevitably taken a back seat. Now I think is the time for us to be really pushing the other additional positive benefits of PrEP and putting them to the front of the agenda. And in addition to talking about the pleasures of PrEP, I think we need to talk about the other benefits of PrEP that aren't just about HIV prevention. I know those of you from Scotland who I've been on panels with before know I keep talking about how Scotland has really led the evidence and the debate around PrEP in the UK. England is definitely following behind Scotland in this. And if there's one thing that I've learned from the first year and a half or 2 years of PrEP implementation in Scotland, is that we now know that PrEP is one of the most impactful and effective health promotion tools for bringing people into other sexual and reproductive health services that we've ever seen. So we know from the data in Scotland that there's a significant proportion of people who use PrEP in the first year and 18 months who either hadn't been to a sexual health service in the previous 2 years or have no evidence of them accessing the sexual health service. They came into a sexual health service because of PrEP. And so I think we need to start making these arguments that the additional health benefits of PrEP, whether that's about reducing stress, reducing anxiety, reducing stigma around HIV, around helping people access mental health or chemsex services, whatever they might be, also needs to be reasons why PrEP is a good thing. And pleasure is the other flip side of the coin. I mean, we're really bad as a nation about talking about the pleasures and the joys of sex. So let's use PrEP as an opportunity to really do that and be really unapologetic that having a good, pleasurable sex life is a really, really important and fundamental part of all of our lives, so long as it's consensual. Let's use PrEP as an opportunity to really big up that sex should be and can be pleasurable and is something that we should be talking about as a joyful, amazing, orgasmic experience rather than something that we should be ashamed of.
Thank you, Will. Bibiana and did you want to respond to that? We have a number of other questions. So would you like me to move on to some other questions or would you, Yes,
I just wanted to say that in the African context, sex or certain things are not openly discussed. So we would have to find a way of going around that to talk to the women or to the African community, because that isn't something that is openly discussed about pleasure.
Okay.
Yeah.
Thank you. Yeah. I think I'm going to move on to some of the other questions because they're now all coming through. There are a number of questions, but I think I'm gonna choose some. I think there are some couple of questions that I think ask similar things. So one question is around age groups and is it better for women to receive information from women their own age as well as their own ethnicity? But I think I'm going to ask the panel to respond to this and to the question of how do we encourage education around sexual health and relationships to be more inclusive of African women, to the needs of African women. So Bibiana, do you have any response to those comments or questions?
Yeah, let me answer the one on age. So I think it all has to do with trust. So the person delivering the message has to be seen as a trusted person. So, for example, in African communities, almost every African will identify with a faith. So they will either go to a church or a mosque. So those faith leaders are trusted people. So those are the people that we need to target to be able to give the right messages. But many of them pose as barriers, you know, to engaging with us. So we need to try to go into those systems and encourage pastors to have an awareness about PrEP so that they can deliver these messages to their congregation. Because we as health workers, if we go in and do the talk, or we as community workers, they tend not to trust us as much as they trust the people who they believe are, you know, are their leaders. So those are the kind of people that will speak, and then people from any age in the African communities will listen to. And again, in my other example, I said healthcare workers are also trusted people. So they need to start to engage with people about HIV drugs and PrEP. So this should be triggered at any visit. Just as you would go and you will access, like I was saying, birth control, or they'll speak to you about mammogram if you're of that age, or they speak to you about, you know, aging. It should be spoken about when it comes to PrEP and HIV treatment for Africans and people who are at risk of being affected. We know that people of the African community are at high risk. So I think these discussions should be done by people who are seen as trusted. And this does not mean that people who are doing grassroots level work shouldn't continue doing their job, but we need to have access into those communities where these people go to. And this, the onus goes on the religious leaders accepting the work we do and allowing us to come in and raise awareness about such issues.
Thank you, Bibiana. I have another question here that is perhaps directed at Ya's story. So yeah, I'm going to ask you first about this, but it's also open to the panel. If the panel members could redraft the guidance on providing PrEP, what would you like to see written down without being thought to be racist?
I just think from a point of, I'm looking at it from a point of a woman who wants to take control of her body and knowing that I might be at risk coming, there should be, you should be able to just go to any clinic, or PrEP should be accessible to all, like the way you go to your GP and you can get a birth control tablet. That is how I see it, that there shouldn't be conditions. Maybe the only thing is to get tested and then give the person PrEP, because people are coming from different backgrounds and different cultures. And sometimes it might not be racist. It might be that the person is just naive, not knowing the culture of somebody else. For example, she's saying that she needed a condom. It's no brainer. People think, why is it that you can't tell your husband not to wear a condom? And because of that, I consciously asked about 10, 20 different African men, if you were in this situation, would you wear a condom? And they would say no. So I just think there shouldn't be barriers, like what Will was saying, that when they started to promote PrEP, it was to do from the cost effectiveness point of view. It doesn't make sense telling her to go back and come back and get tested, because that would have been more cost at the end of the day. She wanted to protect herself. So I think we shouldn't put barriers the same way we look at birth control, access to birth control to women. That is how PrEP should be. We should really try and normalize PrEP for everybody.
Thank you, yeah. There's a comment here, and apologies to the audience if I'm not answering your questions or asking your questions. It's not personal, I promise. But there's a comment here from Chisomo Kalinga, who's a colleague of mine in Edinburgh. I promise it's not a prioritizing of my mates. But she says, this is an absolutely insightful discussion. Thank you all to the three panelists. I found in my own work that there is stigma, particularly with women involved in cultural practices which are accepted in their region of origin, but might be explicitly illegal in Scotland. Polygamy comes to mind. My approach in dealing with this is different as I work in in Malawi, where the practice is more or less accepted, but we may be missing key areas where someone might be in an arrangement where the stigma is too high to deal with openly. Do you have any thoughts on how to acknowledge working with taboos within African communities? That is not an easy question to answer.
I would say that, yes, African cultures come with certain like polygamy, but at the same time, how would you say if you're in a relationship with somebody and your partner is not being faithful and it's with 2 or 3 different people? It somehow works out the same. So it's for me, it's more of looking at the situation, because even though it might be a taboo here, the polygamy from the point of marrying 3, but you get people who are here in a relationship and maybe have other partners. So from that point of view, we have to look at PrEP from that point of view, than saying that, oh, because of this person's culture for polygamy, that for me, I'm just looking at it from the point of, for Africa, yes, polygamy is there, but at the same time here, even though it's not practiced, we cannot say people in a relationship that should be faithful, they don't have that same risk where they are with other people. I hope I answered the question correctly.
Just to add on that, in some African cultures, we have this hierarchy and this family dominance kind of thing where the man dominates and he prescribes what needs to be done. So the man can be allowed to use condoms, to have other sexual partners, and that is seen as normal, but that is not allowed for a woman to do. So there's a lot of inequality there. And, so this woman already knows about her husband's or her partner's sexual practices, outside the house, and he's allowed to use condoms, but she's not allowed to. So this is a big issue, because she is at risk here. She's at risk of contracting not only HIV, maybe other sexual health issues. So family dominance and hierarchy plays a very important role in accessing PrEP and other treatments.
Thank you, Viviana, and for that response. I'm looking at the time. I'm wondering if there's time for another question. Heather, you can tell me if we don't have time for another question, but I'm gonna ask this one, and it might be that we go away and think about it. How do we, oh, I've been told there's time, great. How do we encourage predominantly white HIV sexual health sector leadership to prioritize the needs of people from African communities when it comes to PrEP or wider HIV services? Who wants to respond?
I think we have to stand back or actually research on the culture of Africa, because one thing is, from my experience, Africa is lumped as just one continent, whilst we are from different, like our cultures. West Africa's culture is totally different from East Africans and South Africans. So for example, I'll give an example of HIV and the way maybe people from South Africa and East Africa would approach it. In West Africa, there is a huge stigma that West Africans don't want to discuss about it. So these are all the things I think we have to look at, and also look at how culturally Africans approach things, because we look at it as just one country, whilst we are a continent with different parts. West Africa, the way they look at things is totally different from East Africa, North Africa, and South Africa. So for me, that is an important part. Don't just look at it from the point of Africa as a country, but also look at it from the different parts of Africa.
Thank you, Will, your microphone's off. You have 30 seconds.
It should be on. Can you hear me?
Yeah.
I mean, just as Yar said, stand back. I think it's an absolute travesty that, coming into the 4th decade of HIV, We have organizations that are attempting to target HIV prevention at one of the key target groups. And we see trustees, advisory groups, senior management teams with almost exclusively white faces. Stand back, equip, resource, make space, hire people who are African, hire people who aren't white, find the time. It's an absolute travesty. I could, you know, it maddens, absolutely maddens me.
Or support the African charities that have the knowledge, that understand the culture and can go to their people. Fund us to do the projects that we need.
Absolutely.
Thank you. I think that's an excellent point to end as we are over time. So thank you very much to the panelists, Will, Bibiana. Thanks to Heather for chairing. And thank you to everyone for your questions and comments. I think this is going to continue. This conversation is going to continue as we move forward. So I look forward to having those conversations with you. Thank you very much, everyone.
Thank you.
Thank you.